Skin cancer is differentiated based upon the type of skin cell that's involved. There are three main types of skin cancer: basal cell carcinoma, squamous cell carcinoma, collectively known as non-melanoma skin cancer, and melanoma. Diagnosis of skin cancer starts with naked eye skin examination of the characteristics of the lesion, as well as detailed history of the current skin complaint, asking for time of onset, duration, location, evolution, and symptoms. This is then followed by dermoscopy. Dermoscopy is a non-invasive in vivo technique used for the evaluation of skin lesions. It allows for the visualization of subsurface skin structure in the epidermis, dermoepidermal junction, and upper dermis, which are otherwise not visible to the naked eye. There are three dermoscopic criteria to predict malignancy of a pigmented lesion: asymmetric distribution of colors and structures within a lesion, blue-white structures, and atypical network. On the other hand, for non-pigmented lesions, the three criteria are ulceration, white zones, and vascular structures and patterns. Now, the main purpose of dermoscopy is the evaluation of pigmented and non-pigmented skin lesions to help decide whether or not to monitor the lesion over time with sequential digital dermoscopy imaging to determine its biologic nature, or to perform a skin biopsy, which is needed to confirm diagnosis of skin cancer, showing the type of cells involved. Biopsy can also serve as the definitive treatment for lesions that haven't spread elsewhere. The three main types of skin biopsy are shave biopsies, punch biopsies, and excisional biopsies. In shave biopsies, a superficial thin piece of skin is removed from the surface using a small sharp blade, so they are typically used for lesions for which sampling of the full thickness of the dermis is not necessary. On the other hand, punch biopsies involve the removal of a core-shaped piece of tissue using a sharp cutting tool, allowing to sample the deep dermis as well. Finally, excisional biopsies consist of the removal of an entire area of skin, including the entire lesion and the portion of normal skin around it, using a scalpel, and this is the preferred procedure for pigmented lesions. The most common type is basal cell carcinoma, which involves cells in the stratum basale. Basal cell carcinomas can appear as well-circumscribed, pearly, waxy, or shiny solid elevation of skin with small blood vessels running over it. Now, these tend to be slow-growing tumors that rarely metastasize to distant regions of the body or result in death, but can be locally invasive, spreading over several centimeters of the epidermis. And they can break through the basement membrane and invade the dermis. In fact, basal cell carcinomas can frequently become ulcerated. A skin biopsy shows how tumor cells on the periphery of islands typically arrange themselves in a line, like fence posts, forming a palisading pattern. The selection of appropriate therapy depends upon lesion characteristics, such as size, location, and pathologic features like aggressiveness. Whenever possible, the first choice for treatment is surgery, which is typically performed in an outpatient setting. Surgical excision is the removal of a chunk of tissue using a scalpel, and the surgical defect typically is immediately repaired either by side-side closure or the use of adjacent tissue flaps or skin grafts. A major disadvantage of surgical excision is that it's invasive, and variable amounts of healthy tissue must be sacrificed to achieve acceptable cure rates, which may lead to undesirable function or cosmetic results. Re-excision is an appropriate option for incompletely excised lesions. Adjuvant radiotherapy is another option when surgical excision has been done incompletely, as well as for the treatment of basal cell carcinoma in individuals who are poor candidates for surgical intervention. Now, a specialized surgical technique is called Mohs micrographic surgery, or simply Mohs surgery, in which the tumor is surgically excised and then immediately examined under a microscope to verify sufficient margins before the surgical repair of the site. If the margins are insufficient, more tissue is removed until the margins are sufficient. This allows control of the tumor margins while minimizing the amount of normal tissue that must be resected. Curettage and electrodesiccation may be an alternative treatment for individuals who may not tolerate surgery or prefer not to undergo surgical excision. First, curettage is performed using a round knife, or curette, to scrape off the cancer down to the dermis. Electrodesiccation is then performed by burning the exposed dermis with an electrical current. The curette is used again over the surgical ulcer to remove denatured dermis down to living tissue, until achieving reasonable safety margins of curettage of normal skin around the visible tumor. Finally, there's cryotherapy, which uses liquid nitrogen to freeze and destroy the tumor. This technique is rarely used for treatment of skin cancer. Now, some superficial cancers may respond to topical therapy, with 5% cream or solution of fluorouracil, a chemotherapy agent, or 5% cream of imiquimod, an immune response modifier. These agents must be applied for several weeks, and they may cause inflammatory reactions. Finally, basal cell carcinoma may be treated with photodynamic therapy, which uses photosensitizing porphyrins that are applied topically to the tumor, and the involved area is then exposed to visible light. The light penetrates the skin and is selectively absorbed by the photosensitizer, leading to tumor destruction. This technique is not often used, since risk of recurrence is pretty high compared to the other treatment options. After successful treatment, individuals should be followed up at least once a year. The second most common type of skin cancer involves squamous keratinocytes, and it can be further divided into 3 stages: actinic keratosis, Bowen's disease, and squamous cell carcinoma. First, there's actinic keratosis, which is a precancerous lesion where keratinocytes are damaged by radiation and begin to overproduce keratin. Actinic keratosis can appear as dry, rough, almost sandpaper-like patches that are surrounded by tan, brown, red, or flesh-colored skin. They tend to commonly form on the lips, face, scalp, arms, ears, and the backs of the hands. Next, there's Bowen's disease, which is an early stage of squamous cell carcinoma, also called squamous cell carcinoma in situ. This usually appears as small, well-circumscribed red elevations of the skin with scaly plaques on top. At this point, the tumor can be found in the epidermis, but is not broken through the basement membrane. If squamous cell carcinoma becomes invasive, it can break through the basement membrane and extend into the dermis, and may even reach the hypodermis. As the lesion enlarges, the center becomes necrotic and may eventually turn into an ulcer. Squamous cell skin cancer is more likely to spread to regional lymph nodes or distant areas than basal cell cancer. For that reason, a deeper biopsy, including the subcutaneous tissue, is necessary for correct diagnosis. On skin biopsy, the keratinocytes are pleomorphic, with hyperchromatic nuclei, and numerous mitoses are present. Actinic keratosis have partial thickness epidermal dysplasia, while Bowen's disease presents keratinocytic dysplasia, involving the full thickness of the epidermis without infiltration of atypical cells into the dermis. And finally, invasive squamous cell carcinomas have dysplastic keratinocytes involving the full thickness of the epidermis that penetrate the basement membrane to involve the dermis or deeper tissues. The degree of cell differentiation may vary, becoming less and less differentiated with more advanced disease. Treatment depends on cancer stage. Actinic keratosis may be treated with cryotherapy, topical therapy with fluorouracil or imiquimod, or photodynamic therapy to prevent its progression. On the other hand, standard surgical excision and Mohs surgery are the first-line treatment options for Bowen's disease and invasive squamous cell carcinoma. Individuals with extensive perineural or large nerve involvement may also benefit from the use of adjuvant radiotherapy, as well as those in which surgical margins are positive and those with one positive lymph node that's no larger than 3 centimeters with no extracapsular extension. On the other hand, more extensive lymph node involvement requires aggressive surgical resection of the nodal basins. Non-surgical treatments may be performed as second-line options, including curettage and electrodesiccation, cryotherapy, photodynamic therapy, or radiotherapy alone. Topical therapy with fluorouracil or imiquimod may be used after the treatment of Bowen's disease, especially for lesions which are larger than 3 centimeters in diameter, and in situations in which healing after the other treatment options would be compromised. Finally, systemic chemotherapeutic agents, such as cisplatin, capecitabine, methotrexate, cetuximab, bleomycin, doxorubicin, and the monoclonal antibody zimiplimab, may be used in individuals with locally advanced squamous cell carcinoma that cannot be adequately managed with surgical excision or radiation therapy, as well as for metastatic squamous cell carcinoma. And again, after getting successful treatment, individuals should be followed up at least once a year. Finally, the most aggressive form of skin cancer is melanoma, which involves melanocytes. Now, melanocytic nevus, more commonly known as a mole, results from the type of melanocyte that overproduces melanin. These moles can be considered precancerous because they carry an increased risk of becoming a melanoma. Melanomas grow horizontally within the epidermis and superficial dermis, and they grow vertically, invading the dermis. Metastasis is most associated with the depth of invasion, and in fact, melanoma is the deadliest form of skin cancer because of its tendency to metastasize quickly. The worrisome signs of melanoma can be remembered using the mnemonic ABCDE, where lesions are asymmetrically shaped, borders are irregular or notched, coloration varies within the same lesion, the diameter is larger than the size of a pencil eraser, and the lesion rapidly evolves over time, quickly increasing in size and can cause skin elevation. These features may be observed with the naked eye and further examined through dermoscopy. For definitive diagnosis, a complete full-thickness excisional biopsy of a suspicious lesion should be performed. An excisional biopsy taking a 1 to 2 mm margin of normal-appearing skin and part of the subcutaneous fat should be performed for lesions suspected to be a melanoma. Biopsy can help determine the tumor thickness, as well as the characteristics of the tumor cells, which typically have large nuclei with irregular contours, and produce melanin in a variety of colors: brown, red, dark blue, and gray. Finally, individuals should have their tumors assayed through molecular testing for the presence or absence of a driver mutation at the V600 site in BRAF. If this turns out negative, they should have their tumor assayed for the presence of a driver mutation in KIT. If melanoma is confirmed, then this is usually followed up with a wider surgical excision of the scar and surrounding normal tissue to reduce the risk of recurrence. The recommended width of surrounding normal tissue is determined by the thickness of the primary tumor. In situ melanomas should get a ½ centimeter margin of normal tissue. For melanomas smaller than 1 mm thick, the approach is to resect with a 1 centimeter margin of normal tissue. Finally, for melanomas larger than 1 mm thick, the approach is to resect at least a 2 centimeter margin of normal tissue. Adjuvant radiotherapy may be considered to improve local control in individuals with risk factors for local recurrence, such as tumors thicker than 4 mm or those presenting ulceration. Now, lymphatic mapping and sentinel lymph node biopsy are indicated for melanomas that are 0.8 mm thick or greater, and in those with melanomas smaller than 0.8 mm if they present with ulceration. If sentinel lymph node biopsy turns out positive, we suggest careful clinical observation coupled with ultrasound surveillance of the positive nodal basin. Complete lymph node dissection is indicated if there is subsequent evidence of regional lymph node recurrence in the absence of distant metastases. Depending on the extent of lymph node spread, the individual will be considered for adjuvant therapy. Individuals with microscopic involvement of a single lymph node may get adjuvant immunotherapy with an anti-programmed cell death 1 or PD-1 agent, such as nivolumab or pembrolizumab, while tumors that are positive for the BRAF V600 mutation may get MAPK pathway targeted therapy with a combination of dabrafenib plus trametinib. On the other hand, individuals with macroscopic involvement of a lymph node, as well as those with involvement of more than one node, should get adjuvant immunotherapy or targeted therapy. Finally, individuals who present with clinically apparent regional lymph node involvement should get complete regional lymphadenectomy. And individuals at high risk of regional recurrence after lymph node dissection may get adjuvant radiotherapy following surgery. This includes individuals with multiple positive nodes, extranodal spread, positive surgical margins, and those with recurrent disease. Finally, there is no cure for metastatic melanoma, but these individuals may still get palliative treatment to manage their symptoms and to prolong survival. Individuals with one or very limited number of metastases may benefit from surgical metastasectomy, which means surgical excision of all metastatic disease spots. On the other hand, non-surgical therapy is indicated for individuals in whom surgical metastasectomy is not appropriate. This may involve radiotherapy or systemic therapy with treatments like immunotherapy, targeted therapy, or chemotherapy. Radiotherapy may have a palliative role for symptomatic localized areas of disease, such as cerebral metastases, bone pain, spinal cord compression, and symptomatic soft tissue metastases. As for systemic therapy, individuals without a V600 BRAF mutation may get immunotherapy with pembrolizumab and nivolumab alone, or in combination with anti-cytotoxic T lymphocyte-associated protein 4, or CTLA4 antibody, ipilimumab. On the other hand, individuals with a V600 BRAF mutation may get MAPK pathway-targeted therapy. Finally, individuals with a KIT mutation may be treated with the KIT inhibitor imatinib. Now, unlike immunotherapy and targeted therapy, cytotoxic chemotherapy has not been shown to increase survival or to induce durable remissions. That's why chemotherapy is generally given as a last resort to individuals who aren't suitable for further treatment with either immunotherapy or targeted therapy. Chemotherapeutic agents that may be used include dacarbazine, temozolomide, carboplatin, and paclitaxel, which are given together, or photomustine. Alright, as a quick recap, skin cancer is differentiated based upon the type of skin cell that's involved, into basal cell carcinoma, squamous cell carcinoma, and melanoma. Diagnosis starts with naked eye skin examination and detailed history, followed by dermoscopy. To make a definitive diagnosis of skin cancer, a skin biopsy is needed, showing the type of cells involved. Basal cell carcinoma involves cells in the stratum basale and appear as well circumscribed, pearly, waxy, or shiny solid elevations of the skin with small blood vessels running over it. Treatment options include removal with surgery or with cryotherapy, where the tumor is frozen off. Radiation, chemotherapy, or immunotherapy may also be options. The first choice for treatment is excisional surgery. Incompletely excised lesions may get re-excision or adjuvant radiotherapy. Individuals who may not tolerate or want to undergo surgery may get curettage and electrodesiccation, photodynamic therapy, cryotherapy, or radiotherapy. Finally, some superficial cancers may respond to topical therapy with fluorouracil or imiquimod. Next, there's squamous cell carcinoma, which involves squamous keratinocytes. Its early, or in situ stage, called Bowen's disease, usually appears as small, well-circumscribed red elevations of the skin with scaly plaques. As it grows, the center becomes necrotic and may eventually turn into an ulcer. First-line treatment is surgical excision. Adjuvant radiotherapy may be performed on individuals with extensive perineural or large nerve involvement, as well as those in which surgical margins are positive, and those with one positive lymph node that's no larger than 3 centimeters with no extracapsular extension. On the other hand, more extensive lymph node involvement requires aggressive surgical resection of the nodal basins. Second-line options include curettage and electrodesiccation, cryotherapy, photodynamic therapy, or radiotherapy alone. Bowen's disease may get topical therapy with fluorouracil or imiquimod. Finally, systemic chemotherapeutic agents may be used for locally advanced or metastatic squamous cell carcinomas. After treatment of non-melanoma skin cancer, individuals should be followed up at least once a year. Finally, the most aggressive form of skin cancer is melanoma, which involves melanocytes. The worrisome signs can be remembered using the mnemonic A, B, C, D, E, where lesions are asymmetrically shaped, borders are irregular or notched, coloration varies, the diameter is larger than the size of a pencil eraser, and the lesion rapidly evolves over time. First-line treatment is surgical excision. Individuals with involvement of a single lymph node may get adjuvant immunotherapy or targeted therapy. Finally, individuals who present with clinically apparent regional lymph node involvement should get complete regional lymphadenectomy, followed by adjuvant radiotherapy if there's a high risk of recurrence. Finally, metastatic melanoma may get palliative treatment, such as surgical metastasectomy, radiotherapy, or systemic medications like immunotherapy, targeted therapy, or chemotherapy.
"62-year-old William comes to the dermatology clinic for a routine skin examination. He has been working as a farmer since the age of 20 and rarely wears a hat or sunscreen. Physical examination reveals a pink, pearly lesion with surrounding telangiectasias on his right upper lip. Right after him, 47-year-old Shelby comes in because of a large mole on her right shoulder that has recently grown in size. She is light-skinned and has many freckles. Physical examination shows an asymmetric lesion, 8 mm in diameter, with irregular borders and variegated brown to black pigmentation. Based on the initial presentation, both William and Shelby seem to have some form of skin cancer. Okay, first let's talk about physiology real quick. Normally, the skin is divided into 3 main layers: the epidermis, dermis, and hypodermis. The hypodermis is made of fat and connective tissue that anchors the skin to the underlying muscle. Above the hypodermis is the dermis, containing hair follicles, nerve endings, glands, blood vessels, and lymphatics. And above the dermis is the epidermis, which contains 5 layers of developing keratinocytes. Keratinocytes start their life at the lowest layer of the epidermis, so the stratum basale or basal layer. As keratinocytes in the stratum basale mature, they migrate into the next layers of the epidermis, called the stratum spinosum, stratum granulosum, stratum lucidum, and finally the stratum corneum, which is the uppermost and thickest epidermal layer. Now, the stratum basale also contains the melanocytes, which produce a pigment called melanin from tyrosine. Melanin is then taken up by surrounding keratinocytes, and it contributes to the color of our skin, hair, and eyes. Now, what's high yield is that melanin acts as a natural sunscreen that absorbs and dissipates or scatters UV radiation from the sun or other sources such as tanning booths, preventing it from penetrating the skin. Now, this is important because UV radiation can damage the DNA of keratinocytes. This occurs mostly through the formation of pyrimidine dimers. Fortunately, most pyrimidine dimers are recognized and repaired by nucleotide excision repair enzymes, which can remove the damaged strand on both sides of the pyrimidine dimer. Now, what's high yield is that sometimes the repair process doesn't work and may leave transcriptional errors and mutations. These errors can occur in proto-oncogenes and tumor suppressor genes, increasing the risk of skin cancer. Alright, so UV radiation exposure is definitely the #1 risk factor for skin cancer, which is why most cases of skin cancer occur on sun-exposed skin regions, particularly the face, ears, neck, and hands. In general, fair-skinned individuals are considered to be at a higher risk of developing skin cancer, and the risk increases with sun exposure over time. Other risk factors that affect the protection and repair mechanisms of the skin can also increase the risk of cancer, and this includes diseases like albinism and xeroderma pigmentosum. Albinism is caused by an autosomal recessive gene mutation encoding any one of the enzymes needed to produce melanin, typically tyrosinase. The result is a dysfunctional or deficient enzyme that drastically decreases the amount of melanin that's made within normal melanocytes. As a result, there's reduced or obliterated pigmentation of the skin, hair, and eyes, as well as an increased risk of skin cancer. On the other hand, xeroderma pigmentosum is a rare inherited autosomal recessive disorder in which nucleotide excision repair enzymes are defective and cannot repair pyrimidine dimers. Individuals affected by xeroderma pigmentosum are at much higher risk of developing skin cancer. In addition, they can present dry skin, extreme sensitivity to light, and hyperpigmentation in sun-exposed areas. Now, skin cancer can be classified based on the type of skin cell that's involved. The most common type of skin cancer is basal cell carcinoma, which involves cells in the stratum basale. Most cases occur in middle-aged or elderly individuals and typically appear as well-circumscribed, pink, pearly, and waxy elevations of skin with small, dilated blood vessels running over it, also known as telangiectasias. In addition, these lesions can frequently develop central ulceration or crusting. Less commonly, they can appear as non-healing ulcers with infiltrating growth or as scaling plaques. The high-yield classic location of a basal cell carcinoma is the upper lip, but are also found on the face and trunk. Basal cell carcinomas tend to be slow-growing tumors that rarely metastasize to distant regions of the body, but can be locally invasive, invading into the basement membrane and spreading through the skin and surrounding structures. Diagnosis is based predominantly on clinical examination, although an excisional skin biopsy can be performed both to confirm diagnosis and for treatment. Upon skin biopsy, the classical finding are nests of basaloid cells with peripheral palisading nuclei. Now, the first-line treatment is surgical excision, while non-surgical candidates can get topical therapies such as imiquimod or 5-fluorouracil, curettage, photodynamic therapy, or radiation therapy. Moving on. The second most common type of skin cancer is squamous cell carcinoma, which has a peak incidence at age 60. Risk factors include not only sun exposure, but also immunosuppression, chronic non-healing wounds, and arsenic exposure. Squamous cell carcinoma typically develops on surfaces exposed to the sun, such as cutaneous surface, including the face, ears, and hands. There are 3 stages of squamous cell carcinoma. First, there's actinic keratosis, which is a precancerous lesion that can appear on sun-exposed skin areas as small erythematous or brownish papules or scaly plaques. The key here is that the lesion typically has a rough, sandpaper-like texture along with central scaling. On skin biopsy, there are atypical keratinocytes that involve partial thickness of the epidermis only while sparing the dermis. For treatment, topical chemotherapeutic agents like 5-fluorouracil can be given, as well as surgery, cryotherapy, or photodynamic therapy. After being treated, individuals should undergo frequent monitoring, as a small percentage of actinic keratosis can go on to become squamous cell carcinomas. Next, there's Bowen disease, which is also called squamous cell carcinoma in situ because it's a cancerous lesion but does not extend into the dermis. It usually appears as small, erythematous, scaly, and well-circumscribed elevations of the skin. They can often be confused for actinic keratosis, but they are typically more red and scaly, and can be tender and bleed. On skin biopsy, Bowen disease presents atypical keratinocytes that involve the full thickness of the epidermis without infiltration into the dermis. Treatment options are the same as those for actinic keratosis, followed by frequent monitoring for progression as well. Finally, invasive squamous cell carcinoma can break through the basement membrane, extend into the dermis, and it may even reach the hypodermis. Now, squamous cell carcinoma rarely metastasizes, but it is more likely to do so than basal cell carcinoma. Another high-yield contrast is that basal cell carcinoma typically appears on the upper lip, while squamous cell carcinoma typically appears on the lower lip. As for its clinical appearance, squamous cell carcinoma can appear as a firm, red, and well-circumscribed elevation of the skin. As the lesion grows, the center may become necrotic and can eventually turn into an ulcer. In addition, some lesions may be painful or pruritic. The diagnosis is clinical, followed by excisional skin biopsy performed both to confirm diagnosis and for treatment. On skin biopsy, invasive squamous cell carcinomas have atypical keratinocytes that involve the full thickness of the epidermis and penetrate the basement membrane into the dermis and deeper tissues. Another classic histologic finding to keep in mind is the formation of keratin pearls, which are deposits of keratin that are surrounded by concentric layers of atypical keratinocytes. First-line treatment is surgical excision, but radiation, chemotherapy, or immunotherapy may also be options. And again, after getting successful treatment, individuals should be followed up. Okay, now for your exams, you may need to differentiate between squamous cell carcinoma and keratoacanthoma, which can have a similar appearance. Keratoacanthoma is a benign skin tumor that originates from the hair follicle. The classic test question will describe a middle-aged or elderly individual presenting with an erythematous, dome-shaped nodule with a keratin-filled center. The best distinction between the two is the fact that keratoacanthomas grow very rapidly and can reach 1 to 2 centimeters in diameter within a few weeks or months. They can also regress spontaneously into an atrophic scar without treatment. Finally, the most aggressive form of skin cancer is melanoma, which involves melanocytes. Unlike basal and squamous cell carcinomas, melanoma has a high risk of metastasis and is the most common cause of death from skin cancer. Risk factors for melanoma, in addition to sunlight, include a family history of melanoma and having many or atypical nevi or moles. In addition, a large amount of melanomas are driven by an activating mutation in the BRAF V600E gene coding for BRAF kinase, which is a proto-oncogene resulting in uncontrolled growth signals. Another common mutation which leads to formation of melanomas is in the tumor suppressor gene CDKN2A. Now, once a melanoma arises, it is characterized by two growth phases. The first one is the horizontal or radial growth phase, where the melanoma grows horizontally within the epidermis and superficial dermis and has a low risk of metastasis. The second phase is the vertical growth phase, where the melanoma grows vertically and invades the dermis, which increases the risk of metastasizing to distant sites through blood or lymph nodes. Now, the depth of invasion is known as Breslow thickness, and it is the single most important prognostic factor for predicting metastasis. In other words, the depth of the tumor correlates with the risk of metastasis. Okay, melanomas can be classified into four major subtypes. The most common one is superficial spreading melanoma, in which the horizontal growth phase is prolonged and therefore the prognosis is good. The second most common is nodular melanoma, which presents as a nodule or lump and has an early vertical growth phase. As a result, this has the worst prognosis of all melanomas. Next, there is lentigo maligna melanoma, which has horizontal growth that is relatively slow and lentiginous, so the prognosis is good. And the last subtype is acral lentiginous melanoma, which arises on the palms, soles, or nail beds, and it most often affects darker-skinned individuals. Now, a good way to check and monitor for worrisome nevi and melanoma is to use the mnemonic ABCDE. Malignant lesions are typically asymmetrically shaped, borders are irregular or notched, there are color variations within the same lesion, the diameter can become larger than 6 millimeters, and the lesion rapidly evolves over time and can cause skin elevation. Definitive diagnosis and treatment are done with a complete, full-thickness excisional biopsy of the suspicious lesion with appropriate margins. Upon immunohistochemistry, melanomas will stain positive for S100, which is a marker specific for melanocytes. If diagnosis of melanoma is confirmed, it is usually followed up with a wide surgical excision of the surrounding normal tissue to reduce the risk of recurrence. Finally, metastatic melanomas that are positive for the BRAF V600E mutation may benefit from drug therapy with vemurafenib, which is a BRAF kinase inhibitor. Alright, as a quick recap, the most important risk factor for skin cancer is long-term exposure to UV radiation. Basal cell carcinoma is the most common type of skin cancer. It originates from cells in the stratum basale and is frequently found on the upper lip. It rarely metastasizes but can be locally invasive. The second most common skin cancer is squamous cell carcinomas, which can have different stages. The first one is actinic keratosis, which is a precancerous lesion with partial thickness of the epidermis. Next, Bowen disease is squamous carcinoma in situ, meaning that it is a cancerous lesion that involves the full thickness of the epidermis, but doesn't invade the basal membrane or dermis. Finally, there's invasive squamous cell carcinoma, which breaks through the basal membrane and into the dermis. It is most commonly located on the lower lip and can spread to lymph nodes, but rarely metastasizes. Biopsy frequently shows keratin pearls. Keratoacanthoma is similar to squamous cell carcinoma, but originates from hair follicles and presents as a rapidly growing, dome-shaped nodule with a keratin-filled center. Finally, the most aggressive form of skin cancer is melanoma, and is often driven by the V600E mutation in the BRAF gene. Melanoma has a horizontal and a vertical growth phase. The vertical Breslow thickness is the single most important risk factor for predicting the risk for metastasis. The worrisome signs of melanoma can be remembered using the mnemonic ABCDE. A is for asymmetry of the lesion, B for borders that are irregular, C for color variations, D for a diameter greater than 6 millimeters, and E for evolution of the lesion over time. Melanoma can be classified into superficial spreading, nodular, lentigo maligna, and acrolentiginous. Okay, back to our cases. William presented with a pink, pearly lesion with surrounding telangiectasias on his right upper lip, which is classic for basal cell carcinoma. This was confirmed with a skin biopsy, which showed nests of cells with palisading nuclei. On the other hand, Shelby came in with a suspicious mole that was asymmetrically shaped, with irregular borders, varying coloration, diameter larger than 6 millimeters, and rapidly evolving over time. These features point towards melanoma, which was confirmed with a full-thickness excisional biopsy. Additional clues include William's outdoor occupation and Shelby's fair skin color, which are all risk factors for skin cancer.
Skin cancer is an uncontrolled growth of cells within the skin. There are three main types: basal cell carcinoma, squamous cell carcinoma, and melanoma. Some skin cancers can be spread to other locations in the body and can be fatal, as seen with singer-songwriter Bob Marley, who died shortly after being diagnosed with melanoma. The skin is divided into three layers: the epidermis, dermis, and hypodermis. The hypodermis is made of fat and connective tissue that anchors the skin to the underlying muscle. Just above is the dermis, which contains hair follicles, nerves, and blood vessels. And just above that, the outermost skin layer, is the epidermis. The epidermis itself has multiple skin layers that are mostly keratinocytes, which are named for the keratin protein that they're filled with. Keratin is a strong, fibrous protein that allows keratinocytes to protect themselves from getting destroyed, like when you rub your hands through the sand at the beach. Keratinocytes start their life at the deepest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of small, cuboidal to low columnar stem cells that continually divide and produce new keratinocytes that continue to mature as they migrate up through the epidermal layers, flattening out to a pancake-like squamous shape as they ascend. But the stratum basale also contains another group of cells, melanocytes, which secrete a protein pigment or coloring substance called melanin. Melanin is actually a broad term that constitutes several types of melanin found in people of differing skin color. These subtypes of melanin range in color from black to reddish yellow, and the relative quantity and rate at which they are metabolized define a person's skin color. When keratinocytes are exposed to the sun, they send a chemical signal to the melanocytes, which stimulates them into making more melanin. The melanocytes move the melanin into small sacs called melanosomes, and these get taken up by the newly formed keratinocytes, which will later metabolize the melanin as they migrate into higher layers of the epidermis. Melanin then acts as a natural sunscreen, because its protein structure dissipates or scatters UVB light, which, if left unchecked, can damage the DNA in the skin cells and lead to skin cancer. Melanocytes can also be found in the dermis, at the base of the hair follicle, where they transfer melanin to the keratinized cells that make up hair. Now, a tumor develops if there's a DNA mutation in any of these cell types that leads to uncontrolled cell division. Typically, these are mutations in proto-oncogenes, which results in a promotion of cell division, or mutations in tumor suppressor genes, which result in a loss of inhibition of cell division. You can think of proto-oncogenes as the accelerator, or gas pedal, and tumor suppressor genes as the brakes. Too much acceleration, or an inability to brake, can lead to runaway cell division. As a result, the mutated cells can start piling up on each other and can become a tumor mass. Some of these tumors are benign and stay well contained or localized, but some can become malignant tumors or cancers, and these are the ones that break through their basement membrane and invade nearby tissues. Malignant tumor cells can get into nearby blood or lymph vessels and travel from the primary site to establish a secondary site of tumor growth somewhere else in the body, and that's called metastasis. Skin cancer is differentiated based upon the type of skin cell that's involved in the tumor mass. The most common is basal cell carcinoma, which involves cells in the stratum basale. These tend to be slow-growing tumors that can be locally invasive but rarely metastasize to distant regions of the body. Nearby blood vessels in the dermis can become dilated to deliver more nutrients as the tumor grows. Basal cell carcinomas can grow superficially, spreading over several centimeters of the epidermis. And they can break through the basement membrane and invade the dermis, forming islands or cords of tumor cells. Tumor cells on the periphery of islands typically arrange themselves in a line, like fence posts, forming a palisading pattern. The second most common type of skin cancer is squamous cell carcinoma, which involves squamous keratinocytes. Now, a precancerous lesion that can turn into squamous cell carcinoma is called actinic keratosis. In actinic keratosis, keratinocytes are damaged by radiation and begin to overproduce keratin. Over time, these damaged keratinocytes can develop into squamous cell carcinoma. An early stage of squamous cell carcinoma is also called Bowen's disease, or squamous cell carcinoma in situ. At this point, the tumor can be found in the epidermis, but it has not broken through the basement membrane. Tumor cells are atypical, enlarged, and overpigmented. As squamous cell carcinoma becomes more invasive, it can break through the basement membrane and extend into the dermis. It may even reach the hypodermis, at which point it's more likely to metastasize. Tumor cells at these more advanced stages typically vary in their degree of maturity, have abnormal shapes, and overproduce keratin, forming pearls. Finally, the most aggressive form of skin cancer is melanoma, which involves melanocytes. Now, melanocytic nevus, more commonly known as a mole, results from a type of melanocyte that overproduces melanin. These moles can be considered precancerous because they carry an increased risk of becoming a melanoma. Melanomas grow horizontally within the epidermis and superficial dermis, and they grow vertically, invading the dermis. Metastasis is most associated with the depth of invasion, and in fact, melanoma is the most deadly form of skin cancer because of its tendency to metastasize quickly. Typically, the tumor cells have a large nuclei with irregular contours and produce melanin in a variety of colors: brown, red, dark blue, and gray. The causes of skin cancer can be both genetic and environmental. By far, the leading environmental factor is UV exposure from the sun or tanning booths. Often, the risk of developing skin cancer increases as sun exposure over a lifetime accumulates. Some viral infections, like human papillomavirus, immunosuppression, and having light skin also tend to increase risk. Skin cancer typically appears on skin that's exposed to the sun. Basal cell carcinomas can appear as well-circumscribed, pearly, waxy, or shiny solid elevations on the skin. They can also be ulcerated and red or pigmented. Actinic keratosis can appear as dry, rough, almost sandpaper-like patches that are surrounded by tan, brown, red, or flesh-colored skin. They tend to commonly form on the lips, face, scalp, arms, ears, and the backs of the hands. Squamous cell carcinoma can appear as small, well-circumscribed red elevations of the skin with scaly plaques on top, which can sometimes ulcerate. Moles can appear as small, oval, tan, pink, black, or brown spots that can be flat or elevated. Finally, the worrisome signs of melanoma can be remembered using the mnemonic A, B, C, D, E, where lesions are asymmetrically shaped, borders are irregular or notched, coloration varies within the same lesion, the diameter is larger than the size of a pencil eraser, and the lesion rapidly evolves over time and can cause skin elevation. These lesions may also be itchy or painful. A tissue biopsy is needed to make a definitive diagnosis of skin cancer, and treatment options include removal with surgery or with cryotherapy, where the tumor is frozen off. Radiation, chemotherapy, or immunotherapy may also be options. And precancerous cells, like actinic keratosis or melanocytic nevus, are typically removed to prevent their progression to skin cancer with cryotherapy or photodynamic therapy, which is where light is used to induce cellular death. So to recap, there are three main types of skin cancer. The most common, basal cell carcinoma; the second most common, squamous cell carcinoma; and the most deadly, melanoma. And they all form from uncontrolled growth of cells within the epidermal layer of the skin. Tumors can remain relatively contained or invade other layers of the skin. The deeper the tumor invades, the greater the risk of metastasis. UV exposure is a risk factor, so areas of the face and body exposed to the sun are particularly affected, like the scalp, lips, ears, arms, and the backs of the hands. Diagnosis is made with a tissue biopsy, and treatments can include physically removing cells with a high risk of developing into skin cancer. Tumor cells are also commonly removed and treated with radiation, chemotherapy, or immunotherapy.